Hi guys, this is Ferdin, and I'm going to be teaching you today about fluids and electrolytes. This is the first episode of Conquer the Shelf, and this is just podcast made by med students for med students in order to simplify some concepts that end up showing up on the shelves from internal medicine to surgery to the boards. So we're going to go over the fluids and electrolytes, which is a very high yield topic. Just a little bit about me. I'm a fourth year medical student at University of Virginia, going into surgery. And hopefully in March, I'll let you know where my match ended up. But for now, it's all about you. Let's focus about the topics. All right, start with the case. You have a 45-year-old male who comes to the ED with persistent vomiting. The emesis is non-bloody and non-bilious. Patient is dizzy when standing up. Blood pressure changes from 105/55 when standing, and then heart rate increases to 130 when standing from 100. So the whole point is this patient is very dehydrated. There's blood pressure changes. What is this called? It's called orthostasis. So let's define orthostatic hypotension. What is orthostatic hypotension? Orthostatic hypotension is a fall in the systolic blood pressure of at least 20 and a diastolic blood pressure of 10 between a supine reading and an upright reading, and your heart rate goes up about 20. The whole point is I don't want you to memorize the algorithm for this. I want you to understand that if the orthostatic hypotension indicates hypovolemia. So when the boards or the shelf or any type of exam tells you this patient is orthostatic, you got to start worrying about some kind of hypovolemia, bleeding, dehydration, that sorts. So let's look at this chart. This chart is very high yield. I don't want you to sit there and memorize the points. I want you to understand that when you get to orthostasis, when you have a pulse rate change and blood pressure change, you at least have a class 2 shock, and that's up to 30% of volume loss. Let's look at specific indications here. So class 1 shock, you lose up to 750 cc's. You don't really have any changes, right? Now, when a class 2 shock, you start getting the heart rate changes. That's up to 1,500 cc's blood loss and up to 30%. So that's that's a lot of blood, right? And the only sign you have is essentially your heart rate's going up. Class 3 shock is your blood pressure is decreased. That's when you get it. So don't trick yourself. When it gets to blood pressure, that means they already lost a lot of blood by that point. So you have to replace it even before they get there, right? The urine output starts getting decreased, and in class 4, obviously, they're confused, lethargic, and going into coma, right? But the whole point is, you see orthostasis, it's at least class 2 shock, maybe class 3, and you need to do something about the volume. So let's go back to the case. Patient is vomiting, it's non-bilious and non-bloody, right? So the most likely contents are from the stomach, right? If it's not non-bilious, that means you didn't get to the ampulovator, so you didn't get to the duodenum. And non-bloody, that means the patient is not having some kind of upper GI bleed that's influencing anything. So it's solely from the stomach. So what's the electrolyte composition of the stomach? The reason being is, if we know the electrolyte composition, we're going to know what the patient is vomiting. That means they're losing that, and we could tell what electrolyte abnormality they're going to get. So the stomach, the bottom line is they have high potassium in the stomach, high chloride, and high acid, obviously. So if you lose a lot of potassium, a lot of chloride, and a lot of acid, what kind of acid-based abnormality are you going to get? Yes, you get hypokalemic metabolic alkalosis. Hypochloremic because you lost a lot of chloride. Hypokalemic, you lost a lot of potassium. Metabolic alkalosis because you lost the acid. So now, the boards and the shelves are getting a little bit fancy. They know you know this, right? So where else would you get the same exact electron abnormality without vomiting? I want you to think about it. Where else would you get a lot of stomach juices out without making the patient vomit? Think of a hospital setting. If you said NG tube, you're right. So I would remember this. This is a very high yield point. So a lot of us are accustomed to see vomiting as the same electrolyte abnormality. But in this case, it's NG tube. So I would remember that. So now, what fluid would you use to correct the issues? We have a hypokalemic metabolic alkalosis. So let's talk about fluids. We have resuscitative maintenance fluids. Resuscitative fluids, they're isotonic, so we're going to talk about crystalloids that have crystals in them, and that's how I would think about it. You have the LR, which is called the surgeon's fluid, and normal saline, which is called the internist's fluid. That's just a little trivia. There's a couple of things I would have you focus on. Look at the osmolarity of normal saline, right? It's about 308, and for humans it's about 280. So it's a little bit hypertonic compared to our body. LR is hypotonic. It's 274 compared to ours. But the important thing is normal saline has only sodium and chloride, right? And I would remember the number for chloride, that 154. Reason being, in normal human, the normal chloride levels is 104 to 109. So this is a lot. We're going to talk about why this is important. And in LR, I would remember there's a potassium in there, whereas normal saline doesn't. So that's a very important point. So the fluid of choice in this case could be normal saline, which is also known as 0.9% sodium chloride, or LR. If we go back to our step 1 days, back to basic science, in the proximal tube, you have a sodium bicarb co-transporter, and it's a 3-to-1 ratio. So if you give sodium, you lose bicarb, a 3-to-1 ratio. That means you correct the alkalosis faster. You're going to take in sodium, and you're going to lose more bicarb into the urine, essentially. Okay, so remember that. So always just pick isotonic fluid on the test when there's acute hypovolemia, vomiting, bleeding, okay? Because that will, for this reason. So what would be the sodium potassium concentration in the urine? Now, this is before resuscitation. So I want you to look at the co-transporters, what we talked about, what their electroabnormality is, and just think about it. So obviously, if they're hypovolemic, water follows sodium, right? So sodium is going to be decreased because you're trying to serve it, right? Now, when we are hypovolemic, hypotensive, what hormone gets elevated in our body? Yes, it is aldosterone, right? So if you remember from back in the basic science day, aldosterone works in the distal convoluted tubule and has the HK and the potassium, secretes potassium into the urine and acid. So you get paradoxical aciduria. So in your urine, you'll have low sodium, high potassium, and high acid. It's called paradoxical aciduria because you're alkalotic, right? You want to save the acid, but because of aldosterone effects, you're losing it, right? This serves as a mechanism where your hypokalemia actually gets worse in the setting of vomiting. It's a very neat picky point that the exams and if you're on the wards, the techniques try to pick up on. But knowing this fact, you could probably nail it now. Let's focus on case number 2. You have a 76-year-old male with a history of ulcerative colitis. He failed multiple medication regimens. What surgical options does he have? So now he has UC, not Crohn's. Put him on steroids, put him on DMARDs. Didn't work. What would we do? Yeah, you do total proctocolectomy. So not total colectomy. You have to remove the rectum too. Remember, UC is non-rectum sparing. So you have to remove the colon and the rectum. And when you do that, you could get an initial interval ileostomy to make sure that the patient survived the surgery well, that anastomosis is going to work. So you put him on an ileostomy first. So if you put him on an ileostomy, now you want to know if the ileostomy is working. So you want to find out how much does the ileum, what's the normal ileum output into the colon each day. And how about the electrolyte contents of that ileum output? All right, so it's about 1 to 3 liters of ileostomy output into the colon, right? So you take out the colon, so it's 1 to 3 liters that's going to go into the bag. You don't have to memorize the nitpicky numbers, but the whole point is the ileum, the output from the ileum, is high in bicarb. So you get a lot of metabolic acidosis. So when you vomit, you get metabolic alkalosis. When you have diarrhea, essentially, you have metabolic acidosis. There's a little nitpicky or little hint for your future careers or for future exams, how to find where the pH is going to go. pH usually follows your bodily excretions. So when you vomit, right, your bodily excretions go above the stomach, right? So your pH is going to go up. When you have diarrhea, your bodily excretions go below the stomach, right? So your pH is going to go down. So this could help you to figure it out. So if you vomit, your pH is going to be alkalotic, right? It's going to go up. You have diarrhea, you secrete a lot of bicarb, So you can have metabolic acidosis. Good pH is going down. So what would be the fluid of choice? Let's go back to this chart. What would you give that patient? Remember, they have metabolic acidosis. We give normal saline or LR. Remember, LR has lactate and potassium in it. So in this case, we would do LR. The reason is, don't get confused with the fact of there's lactate in it, or you think, oh, lactate, that's acid. No, lactate gets converted to bicarb by the Cori cycle in the liver, right? That's even in very hypovolemic patients. The liver is very efficient in its conversions. So bicarb is the ultimate byproduct of lactate. So it's actually an alkalizing solution. So the patient has metabolic acidosis because it's losing bicarb. We're like, oh, I'm going to give him LR because LR is going to get to bicarb. We're going to deplete that bicarb. And you're going to give him volume too. So that's the fluid of choice in diarrhea. Or in that case, ileostomy, high ileostomy output. Burn patient. So they have a burn patient. How much fluid will the patient get? What is their magic formula? So it's the Parkland formula, right? The Parkland formula is 4 milliliters times the body surface area burned in percentage, so up to 50%, right? If the patient is burned 80, you still give him 50%, right? It has to be a whole number, so not 0.5, 50, right? And the weight in kilograms. And you get a total number, right? So for example, let's do a 70 kilogram male, right? So 4 who had a 50% burn. So 4 times 50, that's 200, right? Times 70, that's about 14,000, right? It's 14 liters, and you give the first half in the first 8 hours, then you give the other half over the next 16 hours, right? So what kind of, why would we give, so look at the formula says volume of lactated ringers. Why would we give LR instead of normal saline? Now, for this one, you need to go back to the chart that I showed you. What was the chloride concentration of normal saline? It was 154, right? So what's a normal chloride in our serum or in our lab? What's a normal chloride in the plasma? It's about 104 to 109. So 154 is way too high. Now, do you remember this formula from the anion gap formula, the magic formula? So if you look on the right side of the equation, right, you have the chloride, right, and a bicarb. So if chloride's going to go up, right, what are you going to do to your bicarb? You have to balance the negative charges, right? So your bicarb is going to go down, right? So that's the problem. You have acidosis happening. Now, is this gap or anion gap? So obviously, if your chloride's going up, bicarb's going down, you're accounting for your acid. So it's going to be non-anion gap. And it's going to be non-anion gap, hyperchloremic metabolic acidosis. So that's the reason you do not give normal saline burn patients or patients who require a lot of volume. So for example, your pancreatitis patients. So anyone that requires just more than 5-6 liters. I would think about it that way. It's a very common question that you get on the exams, and also a very common pinpoint question on the wards as well. So I would remember this reason. And you could explain the reason why. Be like, oh, look, anion gap. Chloride goes up, bicarb goes down, so I know what's going on. So now let's focus on a specific electrolyte question that you get asked on the exam. So what's so bad about LR? So this is not an exam question, it's a trivia question. I got asked this a couple of times in my internal medicine rotation. Why is LR bad? So there's a different isomer in lactate that causes inflammation that our body cannot process, but the evidence for it is low. But that was the reasons initially a couple of decades ago when they said LR is bad. It also has potassium, so you don't want to give that function. You don't want to give that to somebody who doesn't have a good kidney function. But I would remember that part. So if somebody who's end-stage renal disease, potentially going on dialysis and electrolyte abnormalities, you would not give them LR. When would you use half normal saline? How about half normal saline on D50? So half normal saline is a maintenance fluid. So you replace the insensible losses. So the insensible losses are what you do when you breathe, when you sweat, heat, when you have fevers, you have more losses. So you replace that. The reason being is you give somebody a hypotonic fluid, right? where's the hypotonic fluid going to go? It's going to go into interstitial space and obviously into the intercellular space. And this is where your insensible losses come from. So you have to replace that. But when would you give D50? So you give D50, and especially think of surgical patients or patients who have just been NPO for days, right? If you don't eat, you lose your glycogen restores. And what are you going to start using as your calories or your source of energy? Obviously, you're going to resort into ketosis, right? And that's not good. So by giving about 50 grams of dextrose, that's what the D50 stands for, right? It's about 200 calories per liter. So that's actually prevents ketosis. And also you put some D50 in your half normal saline or anything below that to prevent, red blood cell lysis. It's a very hypotonic solution. It's going to go into the cell and it's going to burst, so you don't want to do that. So let's now, common question that you asked on the surgical ward. Calculate the daily maintenance fluid for a 70 kilogram patient, calculate the infusion rate from that number, and calculate the hourly maintenance requirement for a 70 kilogram patient. So for that, we have two rules. You have the 150-20 rule, that is for the daily maintenance fluid, right? So 100 milliliters per kilogram for the first 10, 50 milliliters per kilogram for the second 10, and the 20 milliliters for the remaining, right? So if you have a 70 kilogram patient, for the first 10 you get 100, for the second 10 you get a 50, and for the rest you get 20 times 50, so you get about 2,500 milliliters per day. Infusion rate, it's a rate, so you divide it by 24 hours, so you get about 104 milliliters per hour. Now let's look at the 4-to-1 rule, which tells you infusion per hour, right? You do 4 milliliters per kilogram for the first 10, 2 milliliters for the next 10, and 1 milliliters for the last 10. Or last remaining, right? So it's 4 times 10 plus 2 times 10 plus 50, so it gives you 110. And if you look at these numbers, 110 is very close to 104, so whichever one you use, you get roughly the same hourly maintenance fluid requirements. Now let's talk about hypernatremia. So they ask you that. It's usually to water deficit. So that means that somebody didn't drink a lot of water, or somebody had some kind of issues going on that caused them to lose a lot of water, right? So the best thing is to provide oral water if they have access to it. Make sure they're resuscitated. Remember the APCs all the time. You got to worry about circulation. Then if you want, once they're resuscitated, you could correct the abnormality by giving the hypotonic solution. Hypotonics include half normal saline plus D5W, D5W, but you don't want to overcorrect the hypernatremia. It's about 1,200 milliequivalents per day. So remember from back to step 1 days, from high to low, your brain will blow, right? If you correct high sodium to low, it's gonna cause cerebral edema, right? And that's bad. How about hypernatremia? That means you have too much water, right? You have too much water, it's diluting the sodium out. Same thing with hypernatremia. You don't have a lot of water, it's concentrating the sodium. You start with a water restriction. With normal kidney function, you don't do anything unless their sodium drops below 120. If they have neurosymptoms, so seizures, they're convulsing, they're altered mental status, they're not themselves, you could give a hypertonic saline. Make sure you don't correct more than 1 milligauss per hour. And you do it until symptoms improve reach 130. Right? And then remember that mnemonic, from low to high, your pons will die. Right? So pontiomyolysis, that is that's a side effect of overcorrecting hyponatremia. So there's a very high yield facts that show up on the exams all the time, so I would remember this. So let's talk about this case. You have a 47-year-old alcoholic homeless man comes to the ED after he was found unconscious by EMS. He's resuscitated, intubated, due to concerns for aspiration. He's difficult to extubate. On day 3, he started on TPN for nutritional support. Then intern goes in the morning, gets a routine EKG, which shows this. So you see this EKG, what's wrong? So first, I will focus on how long your QT interval is. It's pretty long, right? Your T's are not that peaked, but your QT, look at it's a wide QT, it's wide T, so by the time the T finishes from your Q to your T, it's pretty long, right? It's more than 1 big bar, so 1.5 big bars, it's about 2 bars, so it's very long. So you have a long QT. So what would cause a long QT? Somebody who's homeless, who's malnutrition and start on TPN. The one thing about TPN that you see on the exams is when they're testing you on refeeding syndrome. So refeeding syndrome is seen in malnourished people, seen people who are in refugee camps or who suddenly have access to food, or some people who've been starving for a long time and all of a sudden they have access to food. So it doesn't have to be TPN, but TPN questions are directed for that use. So anything hypokalemia, hypocalcemia, hypomagnesemia after initiation of feeding, it's going to cause long QT. So just remember the hypos, the phosphatemias, anything hypo is going to cause that. So what happens is, if you look at a patient who's malnourished and do before their TPN, look at their labs, their serum electrolytes is going to look normal, right? Because your body's trying to maintain that. But when you start feeding them, all of a sudden your insulin levels are going to rise, and everything's going to shift intracellular. Remember, insulin shifts everything intracellularly, right? And your plasma, you're going to become hypo because you're malnourished. You can't restore your sites, and that can cause a lot of cardiac and respiratory effects. So long QT, it's got torsades and it causes cardiac abnormalities. And remember, what's your muscle that helps you breathe, right? It's your diaphragm. And remember, your magnesium and phosphate come from? It comes from your muscles. So you actually weaken your muscles that cause respiratory depression. That's one of the side effects I would remember. So let's talk about specific electrolyte replacements. Potassium, just replete at 10 milligrams per hour. You don't even want to mess with that unless you know what you're doing. You could do up to 40, but that's beyond the exam. So let's look at a patient. If the patient has potassium level 2.8 and is getting potassium at 10 milligrams per hour, how many hours and how much potassium should the patient get to normalize potassium levels of 3.5? So for that, we need to know how the changes in potassium affect that. So for every 10 milligrams of potassium, your potassium level should go up by 0.1. So from 2.8 to 3.5, you need about 70. And remember, we don't want to give at more than 10 milligrams per hour. So over 7 hours. Also, the patient who you're worried about, a surgery patient who has postoperative ileus, you always want to check their potassium because their hypokalemia can prolong their post-op ileus. So you replace it if there's a concern. Let's say you're trying to replace potassium in a hypokalemic patient. You've even got the expert on board. They're pushing at 40 milligrams an hour. You get an EKG monitoring to make sure everything's okay. But your potassium levels only went up by 0.1. What can be the reason? So hypomagnesemia actually can aggravate hypokalemia. This question gets asked on the boards and also on the wards. It's a very common question that med students will get pimped on. The mechanism is very complicated. You don't need to know. So we'll talk about magnesium later in the podcast. But remember, you always check the potassium and the magnesium together. And make sure if your potassium is not responding, you repeat the magnesium as well. So let's talk about hyperkalemia. So obviously with hyperkalemia, first thing that you'll look for is somebody who has end-stage renal disease, somebody who had some kind of a crush injury that caused cell lysis, somebody who's had compartment syndrome that's causing muscle necrosis, so something that's causing death of a cell. So first thing that you'll see is one of the worrisome signs is if you have peak T waves. The way to think about peak T waves is the T waves are about 90% to the way of your QRS. So if you look here, your T waves are like very close to your QRS height. So that's where you look, that's peaked. So what do you do first? If you see peak T waves, you gotta start with calcium gluconate. So it stabilizes the heart membranes, but it's not doing anything to your potassium levels. So for next thing you gotta do is you gotta shift the potassium into the cells. How do you do that? You start with insulin plus dextrose. Insulin is gonna shift everything inside the cell, just like we talked about in refeeding syndrome, but you also gotta give it a substrate. So you give them some sodium, some glucose, dextrose, and then I'll shift the potassium in. Then you give albuterol, beta-2 agonist, remember, also shifts the potassium inside. but that's shifting. That's very temporary. So you got to start removing it from the body. Kxalate. Kxalate is a potassium exchange resin. It takes a long time, but it's in your colon. Essentially, what it does is absorbs the potassium into your feces, and you kind of poop it out. And then you could do dialysis. Obviously, is also a choice, which just removes it from your body. This is just a quick mnemonic that I found on the web that could help you. Causes of the hyperkalemia. Important ones to know is the ACE inhibitors, acidosis, cellular destruction. Obviously, there's a big one: burns, traumatic injury, compartment syndrome, like we talked about. Hypoaldosteronism. It's not very common to see, but hemolysis is a very important one to know. If you take excessive potassium, but I don't know where you would do. I guess you gotta eat a lot of bananas. If you're renal failure, obviously, so end-stage renal disease, hyperkalemia is a very important one to know. And excretion, obviously, if you can't excrete it, your kidneys are not working, then you can't really control the levels of it. Talk about calcium, hypercalcemia. So think about high calcium level. If you have elevated calcium, your nerve function is low, so that means everything is going to be slowed. If you have low calcium, your nerves are going to be excited, so everything's going to be high. So it's very opposite. So with hypercalcemia, you have delayed nerve conduction, delayed reflexes, and muscle function is low. You're symptomatic usually around the level of 12. 15 is very serious. No matter what the cause, so it could be malignant, it could be primary hyperparathyroidism, it could be different reasons. No matter what the reason, if it's worrisome, you start with normal saline. It just causes your kidneys to excrete it. And then you can give calcitonin to decrease the levels acutely if you're having seizures or you're having symptoms, right, from the hypercalcemia. And for a long term, you could start using bisphosphonates. But the essential point is you start with normal saline to cause diuresis. How about hypocalcemia? Hypocalcemia, remember, it's going to be the opposite. It's going to cause nerve hyperexcitability. So you got the Chvostek sign, the Trousseau's. Chvostek is when you hear it on your cheek, and your cheek is like twitching. And Trousseau's is your like hands are twitching. So for that, you obviously replate the calcium. You could give IV or oral calcium gluconate or carbonate. And then for these hypocalcium, I would think of somebody who had a thyroid or parathyroid surgery. So that's where you got it. It's very important to read the question. Magnesium. Magnesium deficiency or excess has the same effects as calcium. So magnesium is a cofactor in the calcium sensing receptor in the parathyroid, so it needs to release the PTH. So wherever magnesium goes, essentially your calcium is going to go. So you have low magnesium, low calcium. Remember what hypocalcemia is going to cause? It's going to cause hyperexcitable state. So it's the opposite. You have high magnesium, it's going to follow with high calcium. It's going to have hypoexcitable. Remember, so just magnesium follows calcium. Hypermagnesemia, diuretics, dialysis, not very high yield. Hypo, magnesium sulfate, but in torsades, you always give magnesium as your initial management. So it stabilizes the heart membrane, just buys you a little bit of time. These are the side effects. This shows up on your OBGYN shelves and when your OBGYN rotations. And then just a mnemonic is burp, right? So remember, if you have elevated magnesium, right, you're going to have elevated calcium, so everything's going to decrease, right? Your blood pressure is going to decrease because your heart's not functioning well. Urine output's going to decrease. Your respiratory rate's going to get decreased. Your patellar reflex is going to get, well, we already knew that your patellar reflex is going to get decreased, right? Because you have high calcium, you have a hypoexcitable state. And this is the end. Hopefully you enjoyed the show, the podcast. And if you have any questions, please email me, write me, comment below, and hope to talk to you later in the future podcast. Thank you.